I go back to the good old National Health Service, the one that we all love and cherish at the moment in Britain. Nobody can touch it, pain of death. Well, it didn't start the way it is. It didn't start supplying everybody. It actually started by looking after. In fact, this is quite interesting. When they chose, this is about 70 years ago, when they chose to start the National Health Service in Britain, they knew that the doctors wouldn't like it. Okay. So what the government did at the day, he said he would stuff the doctors' mouths with gold. In other words, he would bribe them to do it. But even then, it was just serving a particular group of people at the beginning. You know, there was kind of like a big pilot study in Britain. When that worked, it was then disseminated for everybody. And to be honest, even today, it is not an equal service. It's not an equal service right the way throughout Britain. Anybody will tell you that. So the first thing is, if you know that this is a good idea, do it. As time progresses, as you see how things work, you're then able to disseminate. I mean, you can't always see all the details in the future. You know, you shouldn't wait until you've got all your ducks lined up to go forward. Do it because you know it will work even with this small minority. But eventually, I mean, there's no way that the middle class and the lower middle class of Nigeria are going to allow one group of people just to have decent healthcare. It's not going to happen. It can't.
Yeah, I mean, we have a more tactical approach as well, which is that Aetna, as an insurer, actually serves multiple segments, right? So we serve the significant managed Medicaid business. And one of the frustrations we actually encounter is that as an innovation group, we are looking for solutions in that space as well. And when you come by with like, hey, here's a iPhone application that does amazing things for poor people, it's like, well, yeah, but they gotta get an iPhone. Did you remember that part? So, and then well, mobile tech is being adopted, but no. Okay, so there are other things, and I'll give you another example. We've been looking at, for example, Tai Chi and yoga with respect to falls prevention, right? There are some populations for which digital strategies need to be just tweaked a little bit if you're talking about innovation outside of the digital realm. It's those that I have a lot of hope in terms of innovators that can think outside of let me build an app for whatever and with a login. Yes, I know. Great that you just learned Ruby on Rails. Hooray. There's a little more nuance to that. The one thing I'm struck by is that this is actually top of mind for a lot of our policymakers. If I can switch hats yet again to the Federale thing. I was in a meeting with Secretary of Veterans Affairs, Eric Shinseki, and we were talking about data requirements for the genomic era that's about to approach, right? We have orders of magnitude of data storage and privacy and everything to lock down. He actually literally just stopped for a second. He was like, you know, we have to reflect upon this because the genomic technology that we're talking about, even if it's driven down to a $100 genome, may not be affordable for our planet. And it struck me that actually our policymakers, as maligned as they are in the press, are actually thinking about this regardless of their political party. So I know that's not a great answer, but we actually struggle through those questions a lot, and there aren't very great answers. But to the extent that the startup community can engineer solutions that are cheap and infinitely scalable, that's great because we're going to love that for the populations that can pay. We're going to make even more profit off of them, but for the underserved, even better because you can actually distribute to them as well.
More? Yeah.
We've heard a lot about the whole electronic community and digital elements of what people are working on. Do any of you look at other technologies in life science, such as new medicines or new devices, and may be likely to impact the future in very positive ways? If we came to you with a new way of doing a blood scan or a new antibiotic, or those things that you find interesting if they had promoted for Mr. Way or a humanistic claim to better society in some way for the record of Chinese.
Yeah, so give us a new placebo at this point. But for the most part, we're not supporting drug development or devices. We are very interested in exploring big data and trying to see, and we are very interested in the citizen science movement and trying to think about how we could help individuals
So maybe
engage.
mobile data as well.
So the discovery, yeah, so we are supporting new ways of reinventing discovery, but not, we don't generally support those specific kinds of projects.
I would look to disruptive, particularly med device. Give you a specific example in sleep apnea screening, right? This is a prevalent condition that nobody knows how prevalent it is and how many people are dying in auto accidents because of it. The standard of care used to be laboratory-based testing where you'd go in all night and sleep in a bed you'd never been in, hopefully. And and do a sleep study there. And it's still done actually for a lot of indications. But the disruptive innovation there was home-based testing. So people have miniaturized devices, made them easy enough to actually self-apply or else for a tech to apply and things like that. And that has brought down by order of magnitude the cost and subsequently made it much more accessible to a much larger population. That type of med device innovation is something will very quickly change clinical policy for just flat reimbursement. This is not something where you actually have to bootstrap with funding. We'll just adjust reimbursement policy. It's not a big deal. Well, it is a big deal, but it's not as big a deal as like single-handedly funding the development of a brand new technology that's on top of something that didn't exist before.
And with respect to the foundation, does it have to be something that's going to be widely distributed to, I mean, if the business itself is a profit ultimate, is that something that you would consider? Are there specific rules with regards to what you would consider?
So we often say is that preference will be given to nonprofits, but we do support for-profits if we're interested in testing an idea. So if that idea isn't going to be tested any other way, and we think that idea can help a much larger population or will change the way we think about a certain condition or a behavior or a treatment, then we're interested. It's not, so we're interested, and in fact, we'd love for you to make money after our funding goes away, and that's our dream.
Anush, do you want to add to that?
No, I mean, we're not looking at life sciences or med
We use a very
device.
specific one.
Well, we are, but I mean, we're looking at the next thing we're looking at is the emerging genomics data and clinical data. I think there's a lot of value there. New York City is actually investing in this whole genomics center, and we're looking at what the future looks like. But I think we're not there yet.
Actually, some of the words you mentioned, I think were very similar for Lori and Henry. You talked about transformation and you talked about scalability, even if you didn't exactly mention these things. One of the questions I wrote down for you is, how do you define success? And that's always difficult, that's always tricky. So I'm curious, when you're looking at an idea, when you're looking at something to be funded, what's the goal for you? What's the ideal for, yes, this will be a successful project?
We're often asked how we define failure. So when you think about Innovation Lab, you're supposed to fail and have a high failure rate, or else you're not really taking the risks that Pioneer is the only team that's allowed to do. And I think what we're focusing, we're asking more. So we have a project will be a success if it does what it was going to do. It will be a pioneering success if it has a change beyond our hopes and dreams. And so we're looking more to, and I would love to see more proposals. Not only, I mean, it's hard enough to get people to say this project will be a success if, and then think of some kind of measurable outcome, but really having them think about, and if this is a pioneering success, this is what the potential that could happen, and certainly there's a lot of steps between here and there. But having your help articulating, and we can help as well. But for each project, I think it's different.
For us, there's a lot of different factors, but two of the most common themes are, one, the assembly of the business case and whether or not it clears. So our unit is actually looking at smaller size deals because it's mostly pilots, but also Healthogen has been looking at concepts in general that they want to incubate internally, and there's a very high standard for what actually gets greenlit as a result, and a lot of the failure is actually in that initial pipe where there's like 50 ideas for one that actually emerges. And a lot of it washes out in the business case. The just assumptions we are making are way too aggressive, or they're ambiguous enough that even a risk-tolerant innovation group just use that as, well, there's nothing we can do to mitigate that risk with this particular approach. The other thing is cultural fit. There's some things that just still don't make sense despite the most innovative group at the entity that you're dealing with. This is not just for Aetna, but any entity, I would imagine, is like to just struggle with who's going to actually own this after we're done if it's a wild success.
Right. That brings me to my last question, after which you're welcome to ask another one, and that is, because you're providing support at initial stages of the project, what happens next? Who then picks up the slack and takes this baby through elementary school, middle school, and then finally, to graduation, to maturity as a full-fledged product?
Well, I mean, for us, I think there's a few levels. The API is really looking for anyone to build a product using clinical data, right? So we think that's could be the unique selling point for your product. That's one thing. For the accelerator companies, it's a 9-month program, so we give them all the mentorship during that time. But when they come out of it is with customers. So these are reference pilots, reference customers they can use to make sales go on. I'll give you one nugget. One of our companies, really early stage, I would say, because of the 4 pilots they had through our accelerator program, they were able to close 20 hospitals in 1 quarter, which is huge. I mean, these are about $200,000 deals per hospital, so it's a lot of money for them. Because they had the reference, from us, they could say 23 providers in Europe picked us as the top 8 out of 250. So I think that's the growth. I mean, we want to, of course, see them to get additional venture capital money, create jobs in New York. I mean, these are the metrics we look at, as well as tools for our providers.
So I could just give an example of, so one of our projects that we supported was called Drug Facts Box. And often we work with organizations that don't have the business savvy that's in this room. There's an idea, there's academics, and what they did was they took, for a particular drug, all of the published literature, including and some of the unpublished literature, and made a very simple box, like you see on the cereal box, that talked about the different, how many studies, what were the side effects were. So you don't have to read all those pages. And then had also some simple tables showing how it compared even to some of the other drugs that tried to do the same thing. So their spread strategy was to have the FDA adopt and the Drug Facts Box, and they had many meetings at the FDA, and people at the FDA were very interested in this resource, and but it couldn't happen for whatever reason with the federal government. They tried for a long time, and it didn't work. So what we did, and we often actually do this if it's needed, is we partnered with the grantee with a consulting firm that helped them develop a business case, and in the end, what I think they will do is license the APIs for this huge database that they have amassed of all of these, so that Walmart could have a Drug Facts Box on their drugs, and other organizations as well.
I've seen their presentation. It was hilarious. It was tragic, but hilarious, because he kept showing a wall, and we went to the FDA, a wall, and over and over and over again. And clearly, they're academicians. They're not marketing people. They're brilliant.
But each project has its own spread strategy, and we try to help as much as we can for as long as we can.
Yeah, I mean, we're kind of on the late phase, so if your pilot actually works with a payer, that's a good place to be. You probably don't need our help after that.
Mm-hmm.
You got a really good proof point under your belt. And the risk I would point out, and the caveat is, I know a lot of you reached out to me, beware that our innovation group is going to rip you to shreds in terms of outcome studying, right? So we're actually not going to let you get away with, here's a press announcement, we landed this deal with Aetna, go show it to your VCs. Mm-hmm. We're also studying the effectiveness of whatever deal it is you landed. And if you don't see that other press announcement in 6 to 12 months that says, and here were the financial savings from doing so, or the clinical outcomes measures, that's a problem for your company. Mm-hmm. So I'm not trying to deter folks from working with Aetna specifically, but beware that other insurers are also paying attention to that. And I would say if there are investors in the room, just also pay careful attention. Yes, they've landed business, but their inflection point is going to be based on the actual value delivery as opposed to the sale.
Mm-hmm. Okay.
A quick question on the Shiny databases, the HIEs. Do you have payer data in there?
Do not payer data. It's clinical data.
Can Aetna merge with you guys and give you payer data?
Well, we're talking about a mashup already with the CarePass team about where the overlap is. But I mean, the challenge is, at least in New York City, there's so many payers we have.
Yes, I know.
New York City. Right now, it's information, it's clinical data in our thing. There's a health benefit exchange that's coming through. It's many different and also an APCD. There's a lot of acronyms there, but right now it's clinical data.
The APCD is all payer claims
Yeah.
claims
Yeah.
database, and
Yeah.
that's it's not easy to engineer. Like
Yeah.
we'd
Yeah.
like to, but it's
There's pockets. I mean, I think in like one area of New York, there is a small APCD within one region, but it's not statewide.
well, just give you a specific technical issue, like just how do you match this person up?
That's right.
Like, how so there are solutions to that, but none of them are obvious. Like they're actually technical.
Yeah, but it's
challenges.
not even matching it, it's looking at it in aggregate, looking at maybe, rather than payer data for, looking at charge data.
Oh.
So are
Yes,
charges,
okay.
are charges included in HIE?
Yeah, so I think you're asking us, you want to look at broad amount of data and make some differences on analytics on that large amount of data,
Yeah,
right?
on regions
Yeah.
and things like that,
Yeah.
so,
Yeah.
you know, Henry has the payer data,
Well,
so
you-
the charge, the cost of charges are very different.
Yeah, but you can go to the
different
Fair
dynamics.
Health people today
That's right.
and get that. They'll charge you for it.
They'll charge
Yeah,
you.
they do.
Yeah.
No, we don't have that.
Okay.
I mean, that's something we're looking at in the future, but not right now.
It's a great question. Interoperability is difficult within a hospital,
That's
let
right.
alone within.
No, I work at one hospital and they have 174 software packages.
Of course, of course.
174, and it's a community hospital, it's not,
Yeah,
it's
it's
not.
small, that's what I was saying, it's
yeah.
small. That's
Murray, you get to ask the last question for today.
There's a question for Henry about patient engagement and measuring clinical outcome because of that. So,
Yeah.
you know, patient engagement is so hard to measure things, right? So people are trying, a lot of people are trying to do maybe clinical trials for mobile apps, things like that. Have you seen companies that have come in and provided good business cases around actually, you know, putting numbers behind, you know, clinical outcomes on patient engagement type of tools, or, you know,
Yeah.
are you guys investing in that kind of stuff right now?
For customers, I don't know if, well, I wouldn't even be able to disclose if we're investing in some of these, but the simple metric is actually participation right now. Because let's say you had something that reduced like a member's cost by $500 like a year or something like that, but only 20% of them sign up. Like, well, that's kind of a lame program. So there are force multiplier type programs out there. A lot of these have been very buzzwordy, like social type approaches or challenges. Kias, Shape Up, you know, Brad, and before Blueprint, that's what he was doing there. And of the like, there's a crop of them emerging in that space. But they kind of need to move to the next level because there's like creative bribery. And then there's actual like, you know, Jedi mind tricks to get people to do stuff, which we're really excited about seeing. Not in a bad way, like I don't want to trick you to not look for droids, but I just want you to not die. Like I want you to care about your own health. That's a great Jedi mind trick to pull off.
You are, and it's on your website, you're developing a preventative care, chronic care portal, right?
Yeah, there's that too. Yeah, so there's,
So are you measuring outcomes from the preliminary?
yeah,
Are you
there's
seeing
a lot
actual
of,
improvements?
yeah, there are a lot of outcomes measures. One of the basic ones, and unfortunately it's more of a vanity metric that you have to go beyond that, but yes, raw participation, there's sort of a value chain that you don't get participation, and if you saw outcomes, you wouldn't find this other measure plausible. So you actually need to consider all of your metrics in a chain, and I can go on literally for an hour
If
on
you could
this.
reduce the incidence of diabetes by one person, you know, you save probably awesome dollars in your payer chain. So if you can get somebody with a behavioral modification program that engages people such that there's even a little bit more
Yeah.
attention being paid to, you know, the preventative care and chronic care maintenance issues. I
Yeah.
would imagine the economic output from that, although it's not proven because nobody's really done this yet, is that having a measurable economic output from doing that would be tremendous. boon to other-
Yeah, and there's a body of academics for those interested in patient engagement measures, like Judith Hibbard over on the West Coast has done a patient activation index. I would argue it's a bit cumbersome in execution, and she's done great things to actually make it cleaner to implement. But correlating the engagement with actual financial results has been the thrust of a lot of academic work that's now finally transitioning into industry. Early on, a guy named whose name eludes me right now, but Dee Eddington up at UMichigan had already started correlating just lifestyle risks, to speak to lifestyle with the economic equation so that insurers would actually finally get, oh, this is why you pay for that. More work in that domain is needed, and we're going to look to partners in the nonprofit side, but we're certainly funding a significant amount ourselves as well.
Well, Alex, do you have any closing remarks? Which you always do.
I always have closing remarks, absolutely. I think we would talk about some of our next events, but we would thank our panel. So thank you, panelists, for. I never want to underestimate the importance of the after event, because I mean, even though this is great and we love talking to you guys, but we actually always have something afterwards so that we can all go hang out someplace and socialize, and really a lot of great business gets done at the after event. So we encourage you all to come too.
Yes. Wu Liangye, 36 West 48th Street. It's
36.
right around the corner.
And it's for dinner or it's for drinks?
It's
What
for
is it?
dinner, it's Chinese, and they have full bar service.
Like you're buying?
And Alex is buying, not really, no, it's affordable, we wanted to do something affordable, and most importantly, Alec Baldwin has been cited there.
Here's the thing.
Yes, here is the thing.
So,
It's like everything, it's like to summarize the whole health challenge is you have to do the right thing. But it always helps to have a little bit of an incentive that's coming from a psychologist.
Absolutely. So I want to thank everybody here. So not all of you for coming and supporting this. We're member supported, so all of your tickets go for our legal fees and our accounting and things like that. So if anybody who actually wants to sponsor in that way, that's great. We can always have more sponsors. I want to thank our panelists. I want to thank Mike Schwartz from Visible Me Productions and Murray for being our check-in dude. Thank you, Murray. And Talia, of course, for putting together this great panel. If you want to hear about what the Jedi Mind Tricks, we also have an event called Killer Apps for Healthy Living coming up, where one of the great Jedi Masters, the two of them, Alex Racy, who created Tweet What You Eat, and Thor Ernstson, who created Careverge and Pioneerville, which you probably heard of. Careverge actually made you do some amazing things. Before you knew it, you'd answer 40 questions about your profile. But then he started his own company. Anyway, so he's going to come and tell you how to design killer apps for healthy living. We'll also have some other great startups. So if you have a great startup that really gets people to do things with great design, that's what we're going to talk about with mHealth and with design at that event, in addition to the Healthcare Pioneers that's coming up. So, without any further announcements or whatever, enjoy the night, and we'll see you guys later.